Now this data, once collected, will be synced with the backend. So even the person who is taking the images will not going to have access to this data after certain time. So the data is totally protected. In certain cases where the mouth opening is less, it's difficult to take images. Thank you. Okay. So this is how we do screening in the outreach areas. So you don't need too much of manpower. A single person can also do screening. And on the left, you can see the AI algorithm working. So it can show whether the region is suspicious or not. And since we are this app is in the initial stage, so this accuracy of the confidence level keeps on improving as the AI algorithm keeps on learning. So this is the whole ecosystem. This is not an app actually. This is a whole ecosystem. You have the people on the front end, the ASHAs workers, ANMs workers, nurses, who goes door to door, who goes in the outreach areas, screen the patient. Then we have the backend system who take care of all the you can say technical stuff. Then we have the remote specialist. We are going to verify the AI findings. Doctors sitting on the platform, they will analyze all the images and then they will check the findings of the AI algorithms, because right now, since it's the early stages, so we can't rely fully on the AI algorithm. And then what are the outcomes? Real-time monitoring, dashboarding of the data. So we know how many patients are screened on that particular area on a particular day. And then what is the scalability? We are working on integration of this entire ecosystem in the national cancer screening programs. The second device is a multimodal autofluorescence and fluorescence imaging spectroscopic device developed by the IIT Delhi. So this device has 4 modalities: autofluorescence imaging, autofluorescence spectroscopy, fluorescence imaging, and fluorescence spectroscopy. So just a bit of detail: when the light strikes any tissue, there are a number of things happens like refraction, and also fluorescence. So we are going to focus on this fluorescence phenomena. So autofluorescence, we are not using any external dyes. In fluorescence, we are going to use a dye. So the whole idea behind the autofluorescence, that in dysplasias, means pre-cancer, and in case of cancer, the free radicals like NADH and FADH are going to increase, and we are going to capture the fluorescence from these biomarkers by our device. So in experimental setup, we have 2 parts: imaging device and the spectroscopic device. This is the imaging device. It is made in a gun-shaped fashion, so it's easier for the operator as well as for the patient. And this is the spectroscopic device. It emits the light on the tissue, and it also collects the spectra, and it is analyzed by our spectrometer. And the first one is the autofluorescence device, second is the fluorescence, and third one is our fluorescence device. This is the first prototype, and this is the second prototype which are currently using in our field. The data collection, we collect the data, we screen the patient at AIMS also, and in the outreach areas also. And till now, we have screened more than 500 patients. And this is how the screening happens. It usually happens in dark areas. And this is the outreach camps. And if you see on the left side, the lady in the green shirt, she's a graduate, she's a PhD from the IIT Delhi. So the whole point of making this AI-enabled device is that even a non-technical person who is not trained in medical health can also use this device, because we are such a large country, such a large number of population, and a handful of doctors. So we can build the devices which can be used by semi-skilled person. So it is going to increase the screening of the patient. Again, a short video about how this happens. So if you can play this. It's a quick video. It will explain you how the whole screening happens. So this is the device which we have built with IIT Delhi. This is the fiber. This is the patient. You can see a lesion on the right side in the right retromolar triangle. So first we clinically examine the patient. Then we use our first device, which is autofluorescence. This is our autofluorescence imaging device, which is using a wavelength of 365 nanometer. We emit the light. We take the images. Then we use spectrometer to collect the spectra. The spectra will show difference in normal and in abnormal. So this is our autofluorescence spectroscopy, 488 nanometer. So we emit the light on the lesional area, we take the images. Those images will be analyzed by our AI models. And then it will tell us whether the patient is suspicious or not suspicious, whether the patient requires biopsy or only follow. So this is the spectrum collected. It will tell us difference between the normal mucosa, the normal oral cavity, and the abnormal. And then we use the fluorescence imaging. We are going to apply a dye. This dye is FDA approved. It is called as fluorescein dye, made up of fluorescein sodium salt. It is totally safe, FDA approved, very cheap, and can be easily applied on the mucosa. So we apply on all the parts of the oral cavity, the lesional area as well as the normal area, because the AI model is going to learn, it is going to find the difference between the normal and the abnormal. So we apply on the both sides. This is the normal part, and first one was the abnormal part, or the precancerous or the cancerous lesion. And then we use our fluorescence device. So now you can see the lesional area is clearly visible. So even a semi-skilled person can also find out that something is not normal. The patient needs referral to a hospital. And then we collect the spectra. Spectra brings objectivity. When we clinically examine the patient, there is a lot of subjectivity depending on the skill of the person. But when we collect the data using medical device, it brings objectivity to it. So we put the light and then we take the images. Again, those images will be analyzed by our AI models. We take images from both the sides, normal as well as abnormal. Okay. So this is the data generated. We have the different kind of autofluorescence imaging and spectra, and this will be analyzed by our in-house built AI models. And this is the, you can see the red line, it is showing a spike. So it's a difference between the normal and the abnormal. And this is how the this is how the report will look like. You can see the red letters. It shows suspicious for oral squamous cell carcinoma. And on the right, on the extreme right, you can see reddish area. So this is the part which has taken up the dye the maximum. So this is the area ideal for taking the biopsies. Okay, now we can move. So this is how we have built our AI models. We have divided our samples into training, validating, and testing set. And since this device is multi-modality based, we are able to achieve a very high accuracy of 96%, sensitivity of 99%, and specificity around 95%. After this initial proof of concept, we have improved our design. The whole point of these devices is to employ them at PHCs and CHCs, so we can do maximum screening at that places. Now to do this, we require a lot of grant. And this grant has been given to us by the Ministry of Education. There was a grant regarding Artificial Intelligence Center of Excellence, and it is given for the health sector. It is given to AIIMS Delhi, and our department is the lead for oral cancer. Now, all this data which we are generating, where to store it safely, and also we have to make sure that this data is available for researchers who want to build their AI models. For that, ICMR has developed a platform called as MIDAS, which is called as Medical Image Datasets. And we are the first one, AIIMS Delhi is the first one to validate this platform. You can see AIIMS Delhi. So we are contributing our oral cancer, pre-cancerous data to validate and co-develop this platform. So this device has already been patent granted, number of publications are there, and it has received number of awards. This is the team from AIIMS and IIT Delhi. And thank you for the opportunity. Thank you very much.
Thank you so much for that talk. What I'm really interested in knowing is, as a dermatologist,
yes, sir.
Fluorescence and autofluorescence will. I'm surprised with the specificity data actually.
Yes, sir.
Not the sensitivity data.
Yes.
Because this is going to happen if you've got an oral erosive lichen planus. It's going to autofluoresce.
Yes, sir.
You put the dye, there will be fluorescence.
Yes, sir.
You take oral pemphigus.
Yes, sir.
It's going to autofluoresce.
Yes, sir.
You put the dye, it's going to fluoresce.
Yes, sir.
So there are several oral conditions where the same thing is going to happen.
Yes, sir.
It's not only malignancies.
Yes, sir.
So that's why your specificity data surprises me no end. Could you explain it?
So because we back up our data with biopsy reports also.
Yeah.
So we have the ground truth.
Yeah. So that's probably the part which you've not mentioned.
Yes,
and something which the audience must know.
Yes, sir.
Because this sounds great on paper,
Yes, sir.
but unfortunately wouldn't work
Yes.
if you are looking at various other conditions which happen in the oral mucosa.
Yes.
So this is for the audience. It would have high sensitivity, but the specificity will not be the number you've mentioned.
right.
So that's something which
Yes, sir.
which
Yes.
which should have come in your
Yes.
talk. So this is it will pick up abnormalities in the oral
Abnormalities, sir.
mucosa, and those abnormalities can occur because of several reasons.
Several reasons. Yes, sir.
If you have recurrent bites,
Yes, sir.
the same thing is going to happen.
Same thing.
So several conditions will show up
Yes.
with this. But yes, it's a good start. You're probably trying to sort of start and
Yes.
validate that. But this, let me tell you, will need a lot of work. I'm going to discuss this with you sometime later. Thank you.
Sure, sir. Sure, sir.
So Professor Renu John, very fortunately, we are lucky that, is on the way. But by the time we have that particular talk, we would request the man behind this conference, Colonel Praful Mohan, to come up and talk to us about the material-vigilance node at AFMC, what he's proposing, something which I feel is a need of the hour. So please, Colonel Praful, go ahead. The stage is yours.
So thank you, sir. Thanks for calling me on stage. And essentially, it's been a great teamwork. This yes, I can claim that I was rather stubborn that we must have a session on medical devices within the presence of a conference on AI in medical education. So somehow it didn't make sense, and I literally had to convince the director and the commandant and also the NMC regional center that we must have it, right? So since we all are gathering, and I must also thank Major Manas Chatterjee who have agreed to chair this session and traveled from so far from Delhi, taking time out from his busy schedule. So, sir, if you permit, I'll talk without any slides for two reasons. One is that this is something which is very close to my heart. Second, that it's a raw nerve, and both these things feed into each other. So before I go into the desirability of material vigilance, I'll just briefly touch upon what happened to the pharmacovigilance. That's a rather sad story, and I'm very sad about it. So this is my second tenure in AFMC in faculty. This time I'm heading the department. In my previous tenure, which started off in 2016, from 2016 till 2019, it was a dead wood. I could not do whatever I wanted to do for various reasons. And in 2019, we had Colonel Shamila, now Brigadier Shamila, who came as the first service head of the department in pharmacology. Department has been quite neglected, and I joined the department 2003 as a resident. Until 2019, hardly 2 additional layers had been put in. So I'll not go into that domain, but what happened after Colonel Shamila came was that we were both very enthusiastic. We knew as pharmacologists that drugs are doing a lot of harm to our patients. We may agree to it, we may not agree to it. We would be fools if we think that drugs are only doing good. No, they are not. 20% of the patients who come to the hospital, they come because of drugs which we give them. At times, we end up doing a lot of harm. Most of you, I mean, all of you are clinicians. I'm sure you agree to it. This 20%, maybe 10%, but that doesn't matter. Point is, it's a substantial problem which we are foolishly ignoring, not addressing at all. So what we did, sir, was we already had a pharmacovigilance center. We tried to ramp it up. We asked the PVPI to give us resource, which they gave.